Yes.
Cool. So it's a little bit updated from 2 years ago. And the whole talk really is about about leg length discrepancy. I'm going to try and take it a little bit slowly. So long as Chi, so long as you speed me up if I'm too slow. But I think that there's certain parts of this that are unclear to certain of us, and I just want it to be kind of maybe a little bit clearer to all of us. Okay, so here goes. So I'd hope to be the slide is playing. I know it's a little bit jumpy your side, and I'm not even sure how we're going to get around this problem when we get to online presentations of clips, because I'm looking at it and there's just a slight bit of lag, a little bit of loss of quality, but what we're seeing is two things. One is the obvious Trendelenburg on the right-hand side, the shoulder, the head dipping into the side of pathology. And at the same time, if you look carefully, well, then at the same time, obviously, is a compensatory equinus on that side, trying to equalize a leg length discrepancy. You can see a tilted pelvis, and be careful of just assuming that the tilt in a pelvis is about Trendelenburg. And that's why I try and make the emphasis about the center of gravity and as a surrogate marker of a center of gravity is the fact that your shoulders and head are swinging over the fulcrum, which is your hip. Chichi, slow me down if I'm going too fast. But you've obviously got a tilted pelvis here, and it's not about Trendelenburg, it's about the fact that you've actually got a short leg. And on that short side, this child is trying to compensate with that equinus. At the same time, and just watch once again for only one thing, is that you also get the impression that the whole torso, look at the shoulders together, are also in addition going up and down. So it's not just side to side, it's not just compensatory center of gravity, it's also an up and down movement. And it might or might not be obvious, but I'm just saying try and have a look for it. Okay, so what's gonna be driving the process of a leg length discrepancy? And I've just got a bunch of stuff here, and obviously there are going to be more. Trauma can cause both over and undergrowth, or over lengthen, under lengthen. So there's generally considered to be overgrowth in usual trauma in pediatrics, and that's because of an increased blood flow. I've pointed this out to many of you. If you look carefully at a child post-fracture, you're going to see that on the affected side, there's increased hairiness on the side of the fracture. That's for two reasons. The one is that you've hidden this thing under the cast and there's been no clothing, no trauma, micro-trauma to rub the hairs away. But the other reason is going to be that the fact is that there's increased stimulus for blood supply somewhere between 5 and 10 times with temporary overgrowth, including the physes. So overgrowth of the bones, but you may also get shortening, which is an acute thing, or you may get long-term physeal damage, and obviously that's going to be a progressive leg length discrepancy. Infection, once again, can be overgrowth, but normally what we see is going to be physeal damage. Remember that with infection comes inflammation, and so Chris Scott tells me that the commonest deformity that he sees is in fact overgrowth in juvenile idiopathic arthritis. So just bear that in the back of your head. Neuromuscular, in particular, polio, has been very important in leg length discrepancy in children. It's a large driving force historically for orthopedics. And there was a significant leg length discrepancy in polio, less so in cerebral palsy. And the reason is that they are two different patterns of neuromuscular disease, the one upper motor neuron, the other lower motor neuron. And polio, hand in hand with it, with the lower motor neuron, severe muscle wasting, comes a more significant leg length discrepancy. Probably the commonest that all of us see is going to be idiopathic. We just don't really know, overgrowth and undergrowth, but beware here. If the whole side of a body is overgrown, that is true hemihypertrophy, usually both the hands and the feet, the one side of the face. It's mandatory for somebody, not necessarily you, but get somebody to look at the kidneys, because there's quite a high association with a Wilms tumor. And every time I check, the American radiology guidelines have a more stringent follow-up. It used to be every year. Then it became every 6 months. Currently, so far as I'm aware, it's sitting at every 3 months, but I'm quite sure that by the time some of you qualify, it's going to be down to about 3 weeks. Whatever it is, teach you that's a joke, by the way. The whatever we take as normal needs for somebody to be following it up. And then obviously the associated syndromes. Here I've got the vascular type events, KTW, maybe neurofibromatosis. And so in this group, I tend to put them into the same group as perhaps polio, and then definitely into the same group as what is going to become a little bit interesting to us a bit later, and that's going to be the congenital abnormalities. So just put that in the back of your head. The trauma is usually fairly straightforward, but the polio and the syndromic and indefinitely the congenital need a little bit of attention. Now we're going to be coming up for a clinical exam, and the candidate must demonstrate the ability to be able to examine a patient. That's what the college is going to ask of us. For me, I think for me personally, and that's not for everybody, but I believe in blocks. And to me, it's important because that's how you stand. That's a reflection of how you walk. And a measurement on a bed, as accurately as you might want it to be, is, I think, often going to be somewhat flawed, but is also not a good reflection of function. Be that as it may, the college is going to want to see you be able to measure from anterior superior iliac spine to the medial malleolus, and from a fixed midline point to the medial malleolus, and the difference between real and apparent leg length discrepancy is not for this evening, it's for the tut, but you get where I'm going with the whole thing. So I'd like both to happen. As a flow, and maybe this is less important now in terms of the current format of the exam, I would have liked to see, if you're faced with a leg length discrepancy, to look at the child, get the shoes off, measure the ASIS, put blocks under the feet until they're equal, build everything up, get an impression, and then take the child to the bed, supine, measure now real and apparent leg lengths, do the Gagliati, and I'll get onto that, look at Brian's triangle, get all of that information kind of hopefully in a relatively smooth fashion, at the same time looking for fixed deformities around the hip, which may give rise to apparent discrepancies. So kind of smooth it off, but that might not be as important anymore. Assess rotation on angular deformities, and be careful here, and it catches all of us out tight. We forget that we've sent a child down, particularly to radiography, that they there have got x-rays, and we assume that somebody's tried to straighten the legs, but that might not have happened. So it may be that child downstairs has never had blocks, number one, or has tried to compensate by shortening a long leg, making both of them now look equal. And I think just when you've done leg length views, have a quick glance at the knee and look, are you getting a shoot through of the knee, or are you getting a true AP? And it might be one of the subtle clues that you're being caught out. Okay. So I mentioned quickly real versus apparent leg length discrepancy. I think it's important clinically, and you're going to be looking for range of motion, both of the hip and perhaps fixed deformities at the lumbosacral junction. We make quite a big deal of Brown's triangle. I'll go into that. This is Galeotti's test, obviously. And so we are evaluating now the difference between femoral and tibial shortening. So the quick question from me is why Brown's triangle at all? And the answer is that the hypotenuse over here, I think, die langsydige sy, and somebody needs to correct me there, but anyway, the hypotenuse is going to change as a function of rotation. But this, the adjacent side, or the side of Brown's triangle, is not going to change with rotation. So there's the answer to that. I think just have a look at it. We're not going to let you go if you haven't. What are the problems? What are the true problems with leg length discrepancy? And maybe I should just put it first, is cosmesis. That's actually why most patients have come to you. They, the parents are concerned because the child has a limp. And I think that it's as well to bear this in mind for later, because a lot of the time we pat everybody on the back and we say, well, not to worry, because there are no adverse events, but we haven't addressed the problem that they came with. So just think about that. There's definitely, because you've got an asymmetrical gait pattern, increased energy expenditure. The whole process of back pain is entirely controversial, and I'll explain why it's happened. Is that in a lot of the studies that have shown fairly conclusively that there is an increased level of back pain with leg length discrepancies have started with a back pain clinic, and then looked at leg length discrepancies, and then thrown it out onto a population standard. But along the way, they've already selected out a group that's already in trouble. And so the reflections are biased. And while there may be an increased incidence in scoliosis, there has not been shown with clarity that a leg length discrepancy leads to increased back pain. So I'm just sticking with that. I've been through this 2 years ago with the update. We can revisit it, but that's state of play at the moment. And then there's always going to be this concept of the well hip arthritis. And I've been through this before. Bear in mind that the theory is this, is that if you stand with your pelvis tilted, then the long leg is going to have a head of femur that's uncovered by an acetabulum. And I get that starting point. And the theory from there is that standing with that uncovered hip therefore leads to edge point loading, and that leads to degeneration and eventually arthritis. And I get that as well. The problem is that the true forces going through your hip are not on bipedal standing. By far the least amount of force you're taking through your hip is on bipedal standing. And when you stand on one hip with the single stance phase, when you've got anything up to about 3.5 times body weight just in standing, then your pelvis straightens out. And so in that stance, single-legged stance, the forces are equal on both sides. They're not discrepant. So it has not been shown to be the case. And then lastly are studies looking at knee arthritis, also kind of myth busted and have not got space. So really what we're left with is a potential increase in energy expenditure and cosmesis. And don't forget the cosmesis. What are our goals? We'd like to have balance. And just bear this in mind, because just making a leg the same length as the other side might actually unbalance things. We'd like to have equal limb lengths once we have a balanced spine and pelvis. We would like to have axial alignment. So correct mechanical weight bearing axis, and I think that's a good general aim. And there would be times where we would leave imbalance. And so I just mentioned here, this spastic hemi may have a better swing through with the spastic leg that remains shorter. That if we equalize this to the same length as the other side may well be a problem. And in addition, with a rigid scoliosis with an oblique takeoff at the thoracolumbar junction, it may not be the best outcome if we equalize leg lengths. How are we going to evaluate it? And ours is fairly standard that we will get an AP. But now there are going to be problems. Remember that if you do an AP from very close up, centered over the knee, obviously with parallax, you're going to get a magnification of deformity at the edges. So really what you want to have is an X-ray from a fair distance, usually over 1.8 meters, and hopefully centered over the middle of your limb, which is going to be the knee. The best is going to be either an orthorentgegram, so that you take 3 separate shots, and I think I've got a slide coming in. There we go. 3 shots, hips, knees, and ankles in the same thing, and that's actually a scanogram. You want something that's going to give you equivalence rather than distorted magnification. We traditionally have had lying leg length views. I've actually gone on to standing views because, to me, functionally, they give a better outcome. CT scans have gone out in terms of evaluating that. They may have a place at some stage. And then hopefully Ash has sent you, I always use the Grulich and Powell bone age, because bone age may become important in evaluating leg length inequality. But I've sent you guys a PDF version of a more electronic form. It's going to be good enough for us. And in fact, it's one of those interesting things. Grulich and Powell, the atlas is becoming increasingly expensive, but not nearly as expensive as the software that's now available to evaluate bone age. So this is what we would normally look at. We would have a 5.5-year-old, and we would say male or female, and you'd start looking at appearances of epiphyses, ossification nuclei, the number of carpal bones, the appearance of your epiphyses, physeal plates, curving. So a whole lot of stuff. It's a little bit of an art form. It's kind of nice to do 3 times a year. It would drive me completely insane if I had to do it once a week. You've got the atlas for your own good. So having got to establishing what we might have right now, we get on to this point about what's going to happen. What's our prediction of the leg length discrepancy? And the paradox of life is that while it must be lived forwards, you can only understand backwards. It brings me to the point that we are in a place that we're trying to make assumptions on fairly limited information, but that is going to guide surgery that might or might not be permanent. So it requires a little bit of skill and a measure of risk. We want to know about timing of surgery. In order to time surgery, we want to be able to predict eventual discrepancies, and there are a few methods that come into place. And I need to say from the outset that I don't favor any one of them over the other. And so when you get your exam, if I put together and this is not just about an exam, but when you sit in your office one day and you're faced with a child who's got a leg length discrepancy, it makes no matter to me whatsoever what you're going to do, but you need to have some plan as to what you are going to do. And so we're going to go through a few of these. When it comes to your own exam, I will provide you with all of these methods in front of you in some format. You can have your cell phone. I'll give you the app. I'll do all of it. But I would like for you to be able to demonstrate an understanding of where it's going to go. So just trying to make a little bit of sense, and I'm going to maybe take you through a bit of a long journey. Bear with me. That your eventual leg length on average 78 centimeters in girls, and this is based on a US population standard. And I know somebody's going to shoot me down because that's not standard for the world, but let's just stay with it for the moment. 82 for boys. Proximal femur contributes 15%. Distal femur and proximal tibia together about 2/3. And then the bulk of the rest of it is made up of the distal tibia. And if Ash has been able to give you the paper on the arithmetic correction, you will see there quite clearly that the figures for distal femur per year is going to be 10 millimeters and proximal tibia is going to be 6. The just check, double check there, Sharonga. So we start with Menelaus, and Menelaus is cheap and nasty. It's convenient. It doesn't need special charts or graphs. It uses chronological age rather than skeletal age, so you don't have to slow down and get a specialized AP of the left hand. And I've said it's cheap and nasty. And in fact, if you ask Ash carefully, he's got a revised method of using Menelaus that's quite sophisticated, and you can ask him about it afterwards. But let's just say that for a start, that we'll agree that girls are going to continue to grow skeletally until 14 and boys till 60. And that for the bones involved, we're going to have 4, 10, 6, and 4 millimeters of growth per year. Fairly consistency. That does change a little bit, but let's take it. I said it's cheap and nasty as a rule of thumb. Remember, this excludes the hindfoot, which is another 4 millimeters a year. And in an expected discrepancy, and I'm now taking you back to the years when we were looking at, for example, polio. We would say it is your current deformity. And let's say you've got a boy now with polio, he's 10 years old. He has a current discrepancy of 5 centimeters. Then you say, well, he's got 5 centimeters and he's got all of this growth here remaining. And so you quickly add all of it up and get 24. And you put in a factor. And for polio, we said that they lost about 1/3 of growth in a limb per year. So we could say that for a whole limb, that we would have this fudge factor, X, that would be the limitation of growth. And so reasonably, we could say, okay, we've already lost 5, and we expect to lose another years of growth remaining times millimeters of growth times this fudge factor. And so all we needed to do is to be able to plug in a fudge factor. And for polio, as I said, we used to say it was about 1/3. It was far less for cerebral palsy. And then specifically, if it wasn't a global disease, if we only had a disease that affected a single physis, for example, the distal femur, then we could say, okay, everything remains the same, proximal femur, proximal tibia, distal tibia, those are all 100%, but we've also lost 100% of the 10 millimeters. In other words, we're going to lose 10 millimeters of growth per year for the rest of bony growth. And so if we are currently 10 years old, I said, we've got another 6 years of growth left. 6 times 10 is going to be another 60 millimeters or 6 centimeters of growth. So Sharonga, I just need you to feed back to me and say, well, so far that seems fairly obvious. And I'm going to move on. So I've got a 10-year-old boy with a Menelaus method. I've got to give him a leg length discrepancy of 4 centimeters. He has proximal tibial rest. And so then just quickly, and I'm going to ask, I'm going to ask you guys just to put it on the group on the chats and say, well, I want to put it on the chats and just say, he's 10 years old, leg length discrepancy at 10 is 4, proximal tibial rest. What is his expected discrepancy? Current is 4. Where are we going to go? Okay, I'm going to type it in, for goodness sakes. Okay. Okay, so I'm kind of happy. We got 4, we have 10 years, we got 6 times 6 is 36, and 4 is going to be 7.6. All right, so we're getting a swing of it. So then we get a little bit more complex because that might work for a child who got polio at the age of 5, and we kind of know where we're going. We've already charted and we've got a feel for it. But what's going to happen now if we have a child who's born with a congenital defect, who's got a deformity of one leg that might change but proportionally to the longer leg? And so Green Anderson came up with charts. Green and Anderson came up with charts. And let's just look at the charts a little bit before we get too involved. Here what the charts look like. Now immediately, you will recognize that they look very similar to the usual growth height charts in children. And in fact, they're very similar. And so what could happen is that if we identify the fact that at an early stage back here, that we had one leg that was sitting on a certain centile and another leg sitting on another centile, that if we track both of those legs through time, and if they stuck to their own centiles, they would end up at a place where we could predict at maturity what the difference would be. So, I mean, just at a very gross example, if one was sitting on the 95th and the other on the 5th, we traced them out then at maturity for a girl at the age of about 14, this difference over there would be the discrepancy between the two. And you know what, it takes a little bit of eyeballing, but so do your normal growth curves. And I'm just going now backwards if I can. And so that what would happen in the Green Anderson curves there would be 2 interval measurements. You needed 3 months between them. You would basically get a fudge factor between them. There would be a ratio, you get a percentage, and you would have a normal limb and an abnormal limb as a percentage of that, tracing it away. But you could, in fact, also just trace the abnormal limb to its own curve. So then came Mosely. I mean, a very talented orthopedic surgeon who recognized that if you simplified the Green Anderson charts, those curves, and mathematically manipulated the data, you would find a straight line graph. So all he was doing was to take that curve and fit it onto a graph, and then arrange that, number one, you would need a number of visits, and that at each visit you would need 3 values. You'd need a normal leg length, a short leg length, and a skeletal age. And so here's how it starts. And now I refer you to the PDF that I should have sent to the group on the Mosely charts. But this would be a chart of a hemihypertrophy. And this is charted at 1994. And at that stage, we have charted out a long leg over here at 70, the shorter leg at 67, and we've dropped down from that point to a skeletal age of 9. Now, when we follow this up, remember that the one thing that is not fixed in stone is the skeletal age. We're going to have to average it out over time. What is fixed in stone is long, short, and the year that we're doing it. So we've marked out, it's going to drive us all a little bit mad. We've marked out long, short, and age. And we come back in a year's time and we mark out long, short, age, And we're starting to form a trend line at the top here of long leg. We're forming a trend line of short leg. And we also are now able, because we have 3 or more bone ages, we can now apply a best guess estimate of a bone age here. And we advance that, we get to maturity at the age of 16 because of a boy. If it is a girl, she's going to be up here. We get to 16 and reflect this up because now we predict where the long leg is going to end up. Okay, so we know that based on this, we've got a long leg that's probably going to approach 93 centimeters and a short leg that looks to me about 87. Now the question is we're sitting in 1997, having seen that we're going to end up with this discrepancy if we apply an intervention to the long leg at a certain point. We know when to act. And now we need to judge when that time is going to be. And so if we take a line parallel to the both femur and the tibia, this is a distal femur and a proximal tibia, epiphysiodesis, we drag a parallel line up here, that's going to be an intervention point. That if we do both, if we'd worked it out better and seen that if at this point we wanted to just do femur or in fact just do tibia, we've already passed that point. So we've missed the boat. Okay. So that's where I got to 92 and 87. Okay, I'm just rehashing what I've told you. We've marked out a long limb point. We're going to mark out a short limb point. We've got an intervention going backwards. Remember that our last measurements got over here. So it basically, we are now at the point of no return. And so we have to intervene here and we have to intervene with both. All right, hopefully that's fairly obvious, but it all gets very complex. Teddy used to walk around with a folder of these. And heaven forbid if you ever lost any of them. Over here would be a typical patient that we would lengthen. And in fact, that lengthening wouldn't be straight up. It would be, because it takes months, go over there and then carry on. Would carry on, this line would still be parallel to that line. It all got inordinately complex, but it was a method of doing things and it works. And you know what? If you want to use this in your final exam, that's fine with me. I had here an example that you guys can do. In fact, you can borrow this whole talk just for a girl, a long and short leg. We plotted it out. We're going to average out a skeletal age here. Sorry, we've got a short leg and long leg. We've got a plotted out average of skeletal ages. We're going to find a maturity line. We're going to get a predicted leg length discrepancy. And at this point, we once again going to be able to go backwards and say, at a point somewhere here, we can intervene. And these are going to be the effects of epiphysiodesis, both distal femur, proximal tibia. But if we take them from the point of where we want to end up, we see that in fact, if we wanted to just do proximal tibia, we're already too late. That the only possible left is going to be the both. Okay, so if there are questions there, I'm going to quickly just slow down and look, because it kind of needs to be clear or not. There's no questions right now. So what are the pitfalls? So the pitfalls are that we assume a 60s, 70s North American, basically white growth. We assume that modern children are equivalent to mid-70s. We know that skeletal age may well be an approximation. It's a bit of a thumbsuck, and we're going to be at best within about 6 months with trained radiologists. We also know that the human growth is going to be influenced by a whole lot of factors, quite apart from population standards. It doesn't take into account the hindfoot, and certain diseases do not have uniform growth, but we'll go into this a little bit later. So, and this is a little bit later. This is Shapiro's growth curves. He has a hemihypertrophy and an atrophy, which is growth curves number 1, which is a fairly uniform increase. And it usually means that there is a symmetry, not between absolute values, but relative values. So when I say symmetry, I mean that your short would be 80% of long. And that's the only one that I really understand. For the rest of them, the fractures maybe makes a bit of sense to me, that you would have a sharp increase in your asymmetry and then plateau out along with DDH. Increasing, decreasing DDH, I don't really understand, and decreasing, don't know. Just be aware that Shapiro has got these growth curves, and that in general, this is the one that we're going to be interested about in terms of, for example, vascular malformations or congenital malformations. So then Paley comes along with Tetsworth, and he goes all the way back to the Green-Anderson curves, and very simply, instead of looking at absolute values, all he does is to say, okay, let's look at what is the proportion of a, let's say, 1-year-old versus 16-year-old boy. And if you have a multiplier for the value of how long a 1-year-old boy's femur is to a 16-year-old boy's femur is, that in fact, the absolute values, the 95 versus 5% centiles, don't make a difference. How to put that another way? If you're a big 1-year-old, you're going to be a big 16-year-old. And so while your multiplier stays the same, it is multiplying a bigger 1-year-old. Does that kind of make sense? The big jump for many of us is that it is based on a chronological, not a bony age. And most importantly, it is validated for other population groups. So we can safely say that it is based on a mathematical model, not on a North American population that was measured once and can never be measured again. So it has been validated for other population groups, and it has been validated for chronology, not bony age. The last significant benefit is that it is a single measure. You can sit now today with a 5-year-old girl, 5-year-old, 5 months, and say, our current discrepancy is X, we predict Y. You don't have to bring them back for another 3 visits, 3 months apart, to get an indication of what's going on. So just mathematically, how does it work? And once again, I'm looking at the chat group and nobody's slowing me down, and Chichi, you're not slowing me down that I can see. Yeah, okay. So the simplest step with the Paley multipliers is to say that if you measure a limb or a limb segment right now, and you've got an age, that will give you a multiplier. And if you multiply the multiplier, that value, by the limb segment or the limb length now, you're going to get that length at maturity. So if you are currently 10 centimeters and the multiplier is 3, you're going to be 30 centimeters. Or you can say that you might have a long leg now and a short leg now. So long is L1 and the short is L2. So therefore, you could also then say that long leg times the multiplier gives you a long leg length at maturity, and the short leg times its own same multiplier gives you a short leg at maturity. And then, having worked out both the long and the short at maturity, you could then subtract them from each other and come up with a discrepancy, which is now your predicted leg length discrepancy. Or mathematically, you could simplify the entire process and say, well, forget about measuring long and measuring short. All you need to know is the absolute difference. So if you know that at the age of 3 years old, with a multiplier of, let's make it 2.5, and your discrepancy is 2, then your maturity discrepancy is going to be 2 times 2.5 is going to be 5. It's a shortcut method. So you can do it long cut. And I think that maybe this is part of my own problem in explaining it, because in my head, often I've already got the age, the discrepancy, and I can see almost before working it out what the discrepancy is going to be, and I haven't gone through all of the back steps. So definitely, if anyone's stuck at this point, slow me down, but just realize that we can go through one leg and get leg, or we could do leg and long and short legs and get long and short leg, or we could just do difference. So the third little document that I've sent you is a very abbreviated form, I think, of the Paley Tetsworth multiplier. And this would be the last thing that I'd probably give you in the exam. If I did a station, and bear in mind that if it's going to be a short question, there's no way that I'm going to expect you to be measuring and multiplying and all of that. I'm going to give you something really simple. And for me, in a boy, the really simple thing is right there. At the age of 4, you are exactly half of your final length. It's the one thing that's just constant to me. So I would give you a 4-year-old boy, and I'd say there, 2. Everyone can multiply stuff by 2. That would be simple for me. I don't want it to be an arithmetic exam. I want it to be an orthopedic exam. And so I would set the whole thing up. Now, be careful here, because the point in the multipliers is, in general, either for vascular malformations or for congenital deformities. It assumes that your one long leg is going to follow its own natural growth path and continually be as long as it was always going to be, and the short leg is going to be similarly short on its own path. So it hasn't had trauma in the middle, it hasn't had some growth arrest, it hasn't had some catastrophic event. It is growing along its own path, and so the Paley Tetsworths, the growth charts and the multipliers are ideally suited for discrepancies that are symmetrical in as much as the one is, let's call it a proportion of the other. Does that make sense? So hopefully then that's going to be clear. And so here's an example. There's a 4-year-old girl. I've obviously thrown it in because I want to be mean. To congenital short femur, current leg length discrepancy is 3. What's the expected discrepancy? Well, we know that current discrepancy is 3. I'm telling you, and I will give you this in the exam, that the multiplier for this age for a girl, because this is not an exam about looking stuff up on the chart, the multiplier is 1.830. Therefore, the expected discrepancy is going to be 3 times 1.83, and 24 is going to be 5-ish. We're happy with that. And so when I ask you, when given the fact that we've got a vague discrepancy in the region of 5 centimeters, we know it's a girl, she's going to stop growing at the age of 14. And so if I want to gain the 5 centimeters only out of the femur, I would do it 5 years before skeletal maturity. If I wanted to do it only out of the tibia, then I would do it 5 centimeters divided by 0.6, because 0.6 is the amount of growth in the proximal tibia. Or if I wanted to do both, I would say 5 centimeters divided by 1.6, because that would be both femur and tibia, And then the answer to that, and now I'm going to punch it in now because I'm getting lost. So let's say I'm going to now work it out. So 3 times the multiplier, 1.83, is 5.49. And I'm now saying 5.49, I want to do both tibia and femur. So I'm going to divide 5.49 by 1.6, because that's 10 millimeters and 6 millimeters. And I get an answer of 3.4 years. So at 14 minus 3.4 years, in other words, 10 years and a bit half, I'm going to do my femoral and tibial epiphysiodesis. That sort of makes sense here. So I've got a final value in my head. I've got 3 options: tibia, femur, and both. And each of those comes with a value. And I would divide the amount of discrepancy that I have that I want to gain by each of those values and work out an approximate age that I'm going to do an epiphysiodesis. So I'm just slowing again. So Michael's got a question: why only the proximal tibia again? So let's say that's I wouldn't do it. She's got a congenital short femur, Michael. I would try and balance femur with femur. Does that make sense? So if I wanted to make her asymmetrical, then I would do the tibia. So that was a stupid example. So I would be going for the femur. But if I missed the boat with femur alone, then I would go with femur and tibia, if that makes sense. So I was just trying to, what I was trying to point out was the various options I would have at my disposal. And in this particular case, my first actual option would be to go for femur alone. But if I missed the femur alone boat, I'm going to go with femur and tibia boat, if that makes sense too. Okay, and then just quickly, so we were faced with the child right in the beginning. We've told the parents that he's got a leg length discrepancy, that he's not going to get back pain, he's going to get hip pain, that we want to improve his mechanics of walking. Now we want to know more or less what are the options available to us. And so we can give him a shoe lift or prosthetic conversion. And remember, a lot of this is based on age at time of presentation, about concerns, about convenience, about what works for you. So if we see a patient early enough, an epiphysiodesis of the long leg is a relatively simple procedure, needs to be done carefully because they will bite you, but otherwise you're going to be okay. We can do shortenings of long legs, and I have in the past, and it's been a long time since we've done it, but it's possible. Or, and this is the interest for many of us at the moment, is lengthening of a long leg, lengthening of a short leg. So suggested protocol, and remember that this is going to vary with time, expertise, what's available to you. But I think from a visible limp that is of concern to the patient or their parent, I think that a shoe raise comes into play. Now, we always say that we can leave a leg length discrepancy of up to 2 centimeters. But I think that if somebody's presented to you to say, well, I'm concerned because people can see that I'm limping, well, then it's a simple matter to give a shoe raise. It doesn't mean that everybody needs it, but I think for the cosmetic input, it's not a big deal. Somewhere between 2 and 5 centimeters, and there was a epiphysiodesis. But I've said this before, as we get better with lengthenings and as our tolerance and our appetite for them increases, we could probably start thinking about lengthenings under 5 centimeters. But remember that that only applies until a lengthening goes wrong, and then you start changing your mind. 5 to 10 centimeters is in the zone that most people will accept that a lengthening is a good idea. And remember that in any one lengthening, we should probably only be lengthening somewhere between 15 and 20% of that existing segment. So if you've got a bone, a femur that is 20 centimeters, you're looking at about about 4 centimeters maximum. And maybe actually at 20 centimeters, you're only looking at about 3. So, and that may, my own criticism in the past, maybe that the over lengthenings, the overreaching is what can be causing problems because you're just stretching things to extreme. Right, and then certainly over 10 stage lengthenings, epiphysiodesis, and then eventually over 15, 20, you start talking the language of reconstructive ablations. So here's a percutaneous epiphysiodesis. There's a metaphyseal shortening, a tibial shortening. I like this, the theory of this to be doing an intramedullary shortening and then nailing. Transiliac lengthenings we did ages ago. Lots of surgery. I'm not sure that it's necessarily a great idea. Wagner is historical. This was an acute lengthening, and an example of Wagner not realizing what was going on. He wanted to lengthen as quickly as possible and then backplate it. And there were extreme side effects, amputations, deaths. This was a technique living on the edge. Obviously, always going to be complications, non-union, soft bones, bent bones. Ilizarov and circular frames, I'm a fan of. But it comes with the problems of circular frames. And one of the ways around this is then cantilevered frames, which then have their own biomechanical properties. It's not a talk for this evening, but I think that between these two, I'm going to just step back one. Just be aware of the significant biomechanical differences between circular frames and cantilevered frames, how forces are aligned, and then lastly, intramedullary nailing, lengthenings. I see now there's a whole lot of nonsense happening about implant rejection and pain and suffering in the US, and the precise nail seems to be coming under a little bit of fire, and I think unnecessarily so. It's going to be interesting to watch that. All right, I think that was it. That is the end of the talk. Chi, I don't see questions on the group. Are there questions your side?
Hi, boss. I have a question.
Yes.
So I just wanted to ask you personally, in your experience, how often do you find that the contralateral epiphysiodesis is as accurate as you expect it to be, essentially? Because when we do it, we go on the idea that proximal femoral growth is 4 millimeters, distal femoral growth is 6 millimeters per year, proximal tibia 6, and so on. But as I understand, that growth is we assume linear growth, but in truth, growth is not linear. In the early stages, the growth velocity is higher, and as the child reaches or reaches close to skeletal maturity, growth velocity decreases, as I understand it. So how accurate is using this assumption of a linear growth when perhaps in truth growth is not linear?
Yeah, so it's not. And so when I said that Menelaus was sort of quick and nasty, I meant it. Where I think Menelaus is actually quite good and does seem to work is that if you do your epiphysiodesis later on in a relatively mild deformity, so under 5 centimeters, is assuming that you're probably within 3 years of cessation of growth, both boys and girls. You actually hit you are aiming to hit the target fairly centrally on. I think it would be a massive mistake to start thinking about epiphysiodesis at the age of 5, for example, without being very, very, very cautious. And I think the cheap and nasty, rough and ready Menelaus would not be applicable. You would need to sit down far more carefully. But think about it now. They're very seldom are you going to be doing long-term epiphysiodesis? So the question kind of answers itself. It inherently is inaccurate, but it's performed in a phase of growth where things are relatively uniform. Does that make sense?
Yes, thank you.
And then just to also to be clear, is I know that in my heart, I am just so bloody concerned about the epiphysiodesis. I don't know, I just see trouble all over the horizon. We ourselves have a fairly low rate of complications, and let's face it, the biggest complicator, the worst complication from an epiphysiodesis is that one or other side is incomplete. Now you've got continued growth, but worse, you've got angular growth. And so I think in fairness, it would be great to go back and look at them. And I can only justify our own, or what would you call it, obsessive compulsiveness about the entire procedure when I chat to my colleagues and work out how laissez-faire they are about the procedure, and then realize that it's well established that other people run into trouble. So I don't think it's something to be taken lightly. I didn't mention, and I know Andreas has started this. Now, I haven't quite jumped onto it yet, but it's being talked about as an option, and that is the inside-out growth modulation via the usual guided growth type plates, the tension band effect. And it seems that potentially there's place for it. But I think my only caution there, once again, is just to watch it carefully, because I think, surgery is one of those funny things. You do an operation now, and you in your head it's kind of over, and you don't really pay attention over the next 6 months, 12 months, 2 years. And in particular, if multiple different people are looking at follow-up x-rays, then angular deformities easily slide out of control. It makes sense. Anyway, I hope that answered the question.
Yes, thank you.
Anybody else? Oh, so there's just the question here about the epiphysiodesis technique. So I was interested that my colleagues up north, instead of removing the outer third of the epiphysis with 2 separate incisions requiring 2 drilling techniques, the whole thing, they simply went in and cleared out the entire middle part of the epiphysis. So the whole inner disc, let's call it the 2/3 on the inside. Listen, we've done both, and I'm kind of happy with both, but in my head, having almost grown up with the inner third, outer third, that's still my go-to, and I'm comfortable with it. And I know it takes a little bit longer, but you know what? I can chase everybody else out the room and do it by myself and just get rid of your. So I'm still kind of happy with it, but I'm saying very, very unequivocally here that all 3 epiphysiodesis. In fact, I didn't even mention the screw epiphysiodesis. I think all of them have got a place, but I do think that if it is one of those things, certain things I'm quite happy to bounce backwards and forwards between techniques. You know this, that I think that that tender Achilles lengthenings can take on multiple forms, but I think that the epiphysiodesis is one of those things that just requires a little bit of pernickety attention to detail, and I've got a setup now, and I'm just happy with it. And so yes, go central, go inside, outside screws, go staples, inside, outside. I really don't mind, but probably my advice would be to stick to one thing and go with it. There you go. And then the risk of fracture displacement, I have not seen in all of the years, in all of the epiphysiodesis that we've done, I've not seen a fracture or displacement of the growth plate. Andreas mentioned to me that by plating, we're going to stay away from the painful epiphysiodesis. I'm not 100% convinced by that. And it's not proving or disproving that discussion between us at all. But the last patient that I did it at Maitland with inside outside plates was the most nightmarish patient we've ever had. It took her 2 weeks to get out of the hospital with simple plates. It was impossible. So I vowed I would never do that again. Anyway, I will obviously do it again. It's just, and I know it's anecdotal, but the pain issue is a pain issue. I'm not sure it's related to the operative technique one way or the other. Okay.